I bring before you another concept in pre-diabetes, which is personalized nutrition. Personalized nutrition, I keep talking a lot of personalized nutrition nowadays because it's a part of genomics, it's a part of gut microbiome and so on and so forth. In next 25 minutes, it's very difficult to put all that technical thought process into a simple language and give it to you. But I want you to get sensitized to the concept of personalized health. The definition of dietetic practice should change. Most of us belong to individual practicing. We've come a long way from community nutrition to independent practitioners. Dietitians have a good clientele. We have doctors supporting us. We have the patients, especially in cities like Mumbai, Pune, Bangalore, Chennai, where we are into metros. We have a lot of people coming to us. And I think each one of us feel that this suits this person, this doesn't suit this person. And we all know we are not alike. And we've been practicing this, and we know that we are always different. But did you anytime think, no two different people are alike, we have all tailor-made diets, so on and so forth. Why is it so? Is it maybe I'm very complex? It may be really thought process to understand that we are all very complex in it. Itna easy hota na 1 plus 1, 2, I eat 1 chapati, get 150 calories. Then why are we as dietitians here? It is not that easy. Calorie intake and output. End of the day, world works on homeostasis, energy homeostasis. Dietetics is in demand because energy expenditure has absolutely zeroed down. We are looking at apps to tell us how much energy expenditure I am doing. And from the ages, what we really lack is expenditure. And with expenditure, the whole thought process scenario changed. We never had this thinking. We always used to do medical nutrition therapy. We always used to talk about calorie, protein, percentages. 15, 20, now we all have, we've learned it. We've learned in our school and colleges, we've learned through exchanges. We've given the patient to make roti khana. Patient बोलता है मुझे नहीं खानी रोटी. So नहीं खाना है. Dietitian ने बोला रोटी खाना है तो खाना है. But is it so simple? In my house itself, I don't look at something which I like as everybody will like the same thing. So someday I said, I'll cook my favorite vegetable today. Tomorrow I'll cook your favorite vegetable. My own 2 children will not have same likes and dislikes. So what this thought process tells me, something different is there. Somebody likes sweet, somebody likes savory. We also say, I don't like sweet. I enjoy sweets. We're all so different. Our taste buds have trained to the thought process. Many times we look at the sweet dish and decide how much to eat the whole meal. And most of you must have done that. The gulab jamun's favorite sweet dish. You all must have done it. 2 gulab jamun khaya, the dietitians out here calculated the calories and carbs and said, I eat 2 gulab jamuns minus the rice in my meal. You balanced it, but you wanted to eat that gulab jamun. We all are dietitians here. How many of us diet here? It makes us feel very odd when people say, uski samne nahi khane ka. When people say, she's dietitian, don't look at our plates. And when we see our plates has everything. So we are also human beings. And what I want to say is that I'm connected to food. I love being with food, and post-eating the food gives me satisfaction. That feeling of satisfaction is, I think, the whole existence of you and me here. I'm sure all of you agree with me. After eating food, if I feel contented, I won't crave, I won't think about food, I'll be off food focus for the whole day. But if I'm not eaten, maybe I'll keep that in mind. I missed my gulab jamun today. I'm dieting, or I'm not eating, or I've not been fed, or I couldn't eat, whatever it is. But that's the impression which left telling me that I have not been in this way of looking at disconnected from food. Oh, that doesn't make me feel. So what am I trying to tell you is we are so different, and the difference is because my genes have something to say, my environment has something to say, and I'm actually getting the puzzles fit between this omics technology. Because this omics is something which is now trying to tell me that your mother likes sweet, you're also liking sweet. Your brother didn't like sweet, but that's okay, your mother likes sweet. So we always related. My mother used to like this, so that's how I am. In my house, everybody is obese, so I am obese. So I've concluded that I'm obese. So the obesity genomics study told me 1990 Human Genome told me, these are the set of genes which tell you preventive nutrition, not the predictive. Preventive. You can know, okay, you're going to be obese, you're going to be pre-diabetic, insulin resistance, whatever. So we blame it on our genes. But we forget that this genes or this gene, whatever we're looking at, is influenced by the environment. And the environment says, exercise, eat clean, muscle fat, your micronutrients. We had a wonderful talk in the morning about micronutrients, and yes, it is true that whenever you have some kind of a stress in the environment or in your health, your gene translates it into some kind of an illness symptomatically, and we call this wonderful technology today as omics. And I started saying this today to all my dietitian friends, let's practice something different. Let's start looking human body not as 1 + 1, 2. Let's start looking at it as some complex system, and I'm trying to understand the behind the scenes scenario and what I can give. I'm in charge of environment. My lifestyle says environment. Food, exercise, micronutrients, all this comes from environment. My IBA tells me how much to give. I've been equipped with that knowledge of how much food I can give. My RDA tells me. Your body composition tells me how much fat and muscles you have, and I need to see how much protein and MNTs I can give, carbohydrate, protein, fat. All that is being now decoded, and we give us something called as diet charts. But we are evolving, friends, and nutrition is dynamically evolving. AI has done 90% job for me. Artificial intelligence can give me a diet chart if I put everything into it. My preferences, everything the artificial. So I think the dietitians, what will we do? We have intelligence, human intelligence, which artificial intelligence doesn't have. That human intelligence is connecting the dots of all this complex mechanism which we are talking about. I'll give you a case scenario on pre-diabetes which will make it much better for you to understand. Because when I say personalized nutrition and I'm coming from an era of community nutrition, I need to make it very clear that what are these dots and these puzzles I'm trying to link? I need to know. And that's why there are a lot of tools in the market. Body composition is a tool we never had. Earlier I used to do waist circumference, BMI. Then we started doing waist circumference. We do now the wrist circumference. We have so many techniques to tell us what I can work on. So another new technique which has come now is genomics, because we are relating genomics in every statement I talk. Every patient tells you, he doesn't want to get the blame of what he is. He says, it's a dead my genes, and most of us do at the same time. I accepted my BMI as 25 to 26. I'm not going to change it. Because it's feel-good factor for me. My genes had 25, 26. Nobody was 22 BMI in my family. I'm 25, 26. My parents were diabetic and born to get diabetic. We accepted it. So when the genes actually come in every conversation of our preventive lifestyle, the nutrigenomics is a tool which I can explore and try to tell my patients how it looks like. Because what I eat, how much I eat, definitely impacts my internal health. And hence, I think today's dietitian should look at molecular mechanism inside my health. Because these are the bioactive components in the food, the gluten, the lactose, the curcumin. We've learned about it. But today we look at it differently. Why? Because I'm relating that as a bioactive component to get into my system and give me an anti-inflammatory impact. Because I'm actually confused to know what is this inflammation all about. A pimple, an acne, it's an inflammation. What is oxidative stress all about? So why me? Autoimmune, why me as an rheumatoid arthritis? Why an ulcerative colitis? Because finally it's an autoimmune, you all agree with me. Medical management has taught us to treat this as symptomatically. End of the day, doctor, if he feels there's no answer to your treatment, he gives you steroids. A steroid is trying to give an image, pseudo-image of feel-good factor in your health, but the challenges is your bone density, your obesity, then we all struggle with it. So should I handle a weight gain with steroid management, or should I look at the existing factor which is actually responsible for me to get into that illness? So what I'm trying to tell you is look at the molecular scenario behind the scene. It's time we start looking at this micronutrients, the third burden of malnutrition, the micronutrient deficiencies, which is triggering this internal stress. Yes, energy homeostasis is the base of our nutrition management. It's very easy. All the diet which wants you to lose weight is eat less. Maybe it's a bariatric surgery or a typical diet plan with different kinds of calorie control meals. But what I'm trying to look at is how that calorie, from which macro and micros it's coming, and internally in my cells, how does it react? So by going ahead, even the research has told us 20th and 21st century, the research is trying to evolve and trying to tell us, look at the food differently. Do not look at it as only calories and macros. There's much, much beyond it. And hence, I think now academic institutes also have started looking at the syllabus-oriented way of working it as into nutrigenomics, nutrigenetics, gut microbiome. And we need to get oriented with these terms. And hence, we'll change the definition of today's screening process. Our screening process is A, anthropometry. B, C, clinical. D, now we have E, environment. F, food, taste, preferences, allergy. G, genetics. So let's change our personalized health, phenotype, genotype, and relate it with environment. And that's nothing but personalized nutrition. And we all do it. We're just adding 2 more tools to it. And trying to get a holistic and integrated approach towards it, looking at how I can look this A, B, C, D, E, F, G into my science of applying it to personalized health. These are all tools which will help me to work better. One step beyond it, precision. And there's so much of artificial intelligence, the gut microbiome, so many tools getting into it, confusing data. But my patient is only interested in weight loss or diabetes remission. He is not interested in all this data. He is confused because that's another area of confusion which we are coming to. And it's only the dietitian, the lifestyle expert, the health coach, whatever you call her, she has that knowledge. Nobody else has that knowledge to get that person out of confusion, because to connect the dots, what actually is the health goal for that patient, is that whole dietitian's job, and that's precision nutrition. Food orient. If B12 is responsible for my hyperhomocysteine and vascular health, why am I beating around the bush with saturated fat and calorie controls and so many? I'll only focus on my supplementation of folate, B6, B9, my priority, adequate proteins, and lifestyle management. But what happens? Hypercholesteremia, saturated fat. Patient says, I'm vegetarian. No, saturated fat. Coconut out, ghee out. Patient gets irritated with us. And maybe the follow-up rate of dietitian is somewhere we have to start looking at. A positive counseling and looking at the root cause, and the result is easier. No? Give 3 months of B12 supplements. Patient will come back to you saying, thank you, it worked. My cholesterol dyslipidemia is better. Think about it. Think about it, the personalized nutrition application in a completely different manner, because looking at the root cause of why the patient comes to you is more and more important. Genomics and genetics, 2 sides of the coin. How my body reacts with the food and how food reacts with me. So simple. And exposome, endocrine disruptors, and all of the exposome which is coming into the scenario is what we are doing, challenging with. All these supplements of bioflavonoids, they don't apply on us because they go through the process of liver detoxification. Micronutrients, no problem. Water soluble gets immediately applied. But if I look at bioflavonoids, the curcumin supplements, remember your liver is responsible for the pathway for them to get into your blood and make them into your more bioavailable form. Why should I take it? Let food be my own way for bioflavonoids, quercetin and gut microbiome will help me do that. Yes, I need to go on micronutrients, but trace elements are toxic if I overdose myself. Bioflavonoids need the liver path if I take it just without having a prescription. So I should be careful, and who's going to do this job? A dietitian is going to do that. This fraternity is so well equipped with so much of knowledge in 4 years of their academics. I think we just have to understand the interpretation and application. And hence, friends, this is where I start looking tomorrow's nutrition science coming in as more of personalized health. So we are in an era of diet-gene interaction. Food, how does it behave with me? Behavior can be in any way, my neurotransmitter behavior, my gut behavior, or my immune system behavior. It can be any behavior. But I want to highlight how does it behave with you. That's for the phenotype, the genotype, all that combined together. And I'm using which omics here? Metabolomics. Looking at active B12 into my diet and making my vascular health much better is nothing. What I'm looking at, the metabolome of your B12 is what I'm looking at. So it's time we start highlighting this and learn about gene-diet interactions. Because what is in my hand is epigenetic modifications, the dietary patterns. Let's look at a simple case and try to apply all this complex thought process which I'm trying to interpret to you. A typical pre-diabetic scenario, let's take it, a metabolic syndrome. Lipids, homocysteine raised, HbA1c 5.7, but not really obese, good exerciser, but he is worried for his vascular health, a pre-diabetic status. And today most of our patients are, we call them orthorexic, too much information about health and they want to work on everything. And they eat everything healthy. And at the end of the day they come to you saying that, look at this, I do everything, still my report is like this. So we have this category of patients also coming to us. So let's take this category, pre-diabetic lipid profile, and see how personalized nutrition can help. He does a good exercise, he eats clean, where am I stuck? So let's look at this scenario and a pre-diabetic conference. Let's highlight how personalized nutrition will help in this status. So when he's eating clean and his BMI is not more, why is he ended in vascular health? Is it a twin cycle of hypothesis? Good exercises, but many times over-exercising, the next session will tell us that how exercise should benefit muscle fat. So is that a poor pre-existing muscle insulin resistance? End of the day, it's positive. Exercise induces appetite. I'm sure all of you agree, and our sports nutritionists also do agree with us. I exercise more, I eat more. So exercise is not an answer for weight loss. Am I right? In fact, you start eating more, so there's positive energy balance. Any positive energy balance. Exercise, alcohol, social eating, whatever it is. So what happens is, in this exercise, in this positive energy balance, the liver and pancreas try to give me a twin cycle of hypothesis, which is really very prominent here, that they started inducing me with hyperglycemia. The reason can be any because of my fatty liver. There's a lot of gluconeogenesis. There's less of glycolysis. Body doesn't use glucose every 2 hours I'm eating. What it says, every time you eat, I convert it into sugar. Sugar says I have to either get converted into triglycerol or adipogenesis or go to liver, and liver says, how much work I should do? I'm done. So fatty liver. Fatty liver gives me increased lipids, VLDL, LDL, and definitely a high insulinemia. And that actually gives me a hyperglycemia. The etiology can be different if I look at this patient. On paper, he is fantastic. He is absolutely to the mark. He eats well. What am I looking at? He does 3-4 days of high intensity exercise, stress, alcohol, social eating, genetics. I need to get into all those details because his sugars are high. I mean, he doesn't want that pre-diabetes to be there. And he says, I do everything. You have to tell me, how is this report related to my lifestyle? Tell me now. If everything is falling in place, then I go back to molecular scenario. If he's ready to do a genomics testing, I'll ask him to do a genetic testing. Gut microbiome, I generally don't get into in this kind of scenarios. It comes only, it's too early to talk about it because we don't have Indian gut analysis still. So the diet are very varied in Indian scenarios, so we won't talk about gut microbiome. But definitely I can look at behind the scene energy homeostasis, oxidative stress, inflammatory stress. Look at the sleep, look at his oxygen level, how he's faring, look at his alcohol, smoking, other aspects which generate oxidative stress. And maybe remember what is heat. When people say there are a lot of heat generation in my body, the menopause or exercise, it's a mechanism of body's energy metabolism. And we all know kilocalories is nothing but heat output. So every heat I generate, I'm burning calories. So it's generating heat. Generating heat is nothing but oxidation. What does it do? For every 1 ATP I burn, so 1 calorie I burn how many ATPs? Go back to your biochemistry classes. 38 ATP. 38 ATP is what I'm generating from a simple glycolysis. But it's not so easy. It takes away B2, B12, B6, selenium, iron. Dr. Manik Prasad Reddy sir was talking about how iron is related to prediabetes. Because to manage this oxidation of 1 calorie, I'm using the battery of micronutrients there. It's not so easy. But my calories are only calories. It can come from 1 teaspoon sugar, or it can come from 1 teaspoon rice or 1 teaspoon dal. You never know. They come from any source of macros which I eat. And I'm equipped with so much of micronutrient battery, and that creates oxidative stress, free radical generation, and then I'm stuck to learn about, oh, is this an oxidative stress? Is this an inflammatory stress? The CRP level tells me for inflammation, genetic testing tells me, but there are genes which talks about oxidative stress, your inflammatory stress. So behind the scene, if these are the reasons, simple, I need to give a lot of antioxidants, give a lot of micronutrients, go slow with the energy, ask the patient to reduce their HIIT and get to yoga. So these are the changes I can start looking at, because I want to minimize the stress, oxidative or inflammatory, whatever reason I have found out for that. And make stress an important factor to look at his free radical generation. And hence personalized nutrition. A lot of studies have been done. The British study, which is a very important study, which talks about personalized response to dietary composite trial, giving a nutrition, like Dr. Ranjani was saying, that they give a lot of community nutrition help, but that's for large data. But when you and me are working on an individual patients, and if I look at how the response is when I talk individually to you and in a community, definitely personalized nutrition is what I'm looking at. So yes, going ahead, personalized nutrition is the way forward, and we are now getting into personalized data generation to work on community. If my population has more of D3, B12 deficiency, I look at folic acid or folate supplement. Do I need to give folic acid? To most guys. Do I need to give folic acid or folate supplement is something which I need to work on. So when patient is hyperhomocysteemia in my case, I start looking what is the nutrient signaling pathway here. Hyperhomocysteemia is what I am looking at. So the B12 deficiency. B12 deficiency definitely means folate deficiency. Now folic acid to folate is a genetic challenge. My body cannot convert folic to folate if I have mutations in my MTHFR. So folate, B12, B6, simple. I integrate it, I make it environment friendly atmosphere for his diet, exercise and all to him, and start translating this into his personalized nutrition. So a lot of areas in diabetes management. What is pre-diabetes? You are looking at the change in lifestyle. There's a lot of heterogeneity. We need to look at the root cause of what it is. A simple diabetes prevention outcome study told that whatever metformin-induced, drug-induced, lifestyle-induced, sustainable weight loss for this diabetes prevention outcome study was 5%. And hence, friends, I think it's time we integrate omics. How beautiful I thought this food omics was that. First job of food, primary is nutrition. I forget when I eat my food. I look at food as happiness and connect. The first job of food in my body is nutrition. Second job is sensory. Feel, smell, taste, happiness, satisfaction, sensory job. The third job of my food is physiological. But if I look at my attitude, I will look first as sensory. Second as physiological. Being a dietitian, I look at sensory as well. So it's time we integrate the omics with diet studies. There's a lot of studies, students out here can think about it and start looking at how this omics can help me to personalize my health. What kind of carbohydrates, what kind of fatty acids, what kind of fiber. If you do a gut microbiome study, we know that there are two major fibers, the prebiotics, herbicides and your lactobacilli. You can start taking, you have a supplement out there which tells you, but most of us have got benefited out of it. So at least 50% of that microbiome I can do. My flavonoids, proteins, which amino acids, leucine or lysine. It's not protein now, it is amino acid. The prescription should start getting into details of your own nutrients-based nutrition is what I would like to say. So there are a lot of genes which actually help us, PPR gamma, most of the drugs, especially metformin, all of us know, work on PPR gamma, adipogenesis is prevented. And if I have a mutated genesis, people say, whatever I eat, thin fat Indians. So is it PPR gamma or it's lifestyle? Right? There's still a lot of data coming out of PPR gamma, MTHFR, FTO. These are majorly studied gene, and we will definitely come out with Indian data on this, then we'll start applying in the community. But individual, yes, you can look at this tool where you can help your diabetic patient to reverse it. So I think it's environment. It's in a family of 3 generations staying together and learning what actually is working on them from childhood to parenthood, that what are the nutrient-based nutrition, the cultural practices, what we need to work on. Then I think the AI will help me with the food-based dietary prescription. I don't need a broccoli, I need to work on sulfur-containing foods. I need to work on malting of cereals and grains. I need to work on fermenting it with my cultural practices to improve the bioavailability. So yes, we should start looking at personalized nutrition as an effective tool in diabetes management, for that matter, any non-communicable or immunological or autoimmune disease, because we have to create algorithms. We have to start looking at algorithms. We call it an integrated systems biology now. It is just not food. It is now exercise, your stress, your genetics, everything drives you to the success of this kind of personalized nutrition. Learn out this new term, integrated systems biology. Don't start looking at disease-based management. Start looking at molecular nutrition, nutrient-based management for your patient. It means a lot. The satisfaction of your understanding of nutrition is much, much more better than just giving do's and don'ts in your diet. The diet prescriptions are no longer do's and don'ts, friends. It is more about looking at nutrition system biology, target organs, target stress in the body, which inflammation, or target vascular health or insulin health, and I think this is where we are changing the nutrition prescription. Phenotype, genotype, and environment. So hence, we are now ushering ourselves into a different way of practice. Food sensitivity, IgA, gut microbiome, nutrigenomics, personalized information, screening, ABCD, and then we come to personalized nutrition. Precision nutrition is one step ahead. A mock gene report to make you help understand how the report looks like. There are a lot of companies now which do genetic testing. What is important is interpretation. Testing is easy, interpretation is a challenge. Only a dietitian can do this, and we are all equipped with that knowledge to understand each and every gene, because we've learned all that in our biochemistry. And that's why I think I come to the end of the talk, saying that we are actually into a personalized nutrition setup for prevention, for mindfulness, for behavior management, and for all the PNIE, that is pituitary, neuro, immuno, endo kind of illnesses, where the medical management doesn't work, nutrition works. So, is it the need of the hour? How does the audience feel at the end of the session? Yes or no? Yes. We need to reach out to people, we need to promote it. We need to give a lot of functional nutrition knowledge to our students, to our fraternity, because the need of the hour is functional nutrition. Identification of biomarkers, developing a food, relating specific nutrition personalized into community, supplementation, fortification. Soil health to plate health. My soil is deficit in a lot of nutrients. I have no choice but to supplement it through the nutrients which is available, making it more bioavailable. Thank you once again for all patients during post-lunch session.